We'll now be starting off with the first session. The first session is on facilitating SMBG with the novel IPDM approach. For this, I call upon the chairpersons, Dr. P.K. Gupta, Dr. Shankar S. Sen, Dr. Aprajita Pradhan, and Dr. Piyush Jain. Onto the stage, please.
We are going to start the session, and today's first talk is by Dr. Deepak Khandelwal. He have a distinguished degrees of MD, DM and MBBS from all leading MAMC medical college, and he has done his DM from AIMS, and he is practicing in Paschim Vihar, and he's okay. So we are going to have a very good discussion, and let us listen to Dr. Khandelwal, and then we will have question and answer session. In the last or in the beginning, sir? Together or separately? Okay. So Dr. Khandelwal, please.
A very good afternoon to everyone. A warm welcome on behalf of SPEED organizing team. I sincerely thanks all the esteemed faculty members and all the delegates for coming to SPEEDCON this year. Sincere thanks to chairpersons for my kind introduction. So this is the topic that I am going to start, facilitating SMBG, that is self-monitoring of blood glucose, with the novel IPDM, that is integrated personalized diabetes management approach. So, when we talk about epidemiology of diabetes in India, we can summarize. This is one editorial we published in 2017 in Indian Journal of Endocrinology and Metabolism, summarizing Indian diabetes epidemiology as a rule of 2/3. So this data has come from large Indian trials like ICMR India DIAP. Important thing, most of these figures, they are approximately 2/3. They are not exactly 2/3, but it gives a lot of insight about Indian diabetes epidemiology. So we can see 2/3 of dysglycemia in our population is pre-diabetes, out of which 2/3 progresses to type 2 diabetes over a period of time. And this conversion of pre-diabetes to diabetes is much higher in Indians as compared to other populations. Then 2/3 of the patients with diabetes, they are diagnosed, means 1/3 patients, they remains undiagnosed. 2/3 of the patients with diabetes, when they are diagnosed, they are young, means less than 50 years of age. Means disease is primarily impacting on economically productive age group. Also, if I see, average mean age of new onset type 2 diabetes in my clinic, the average age may be somewhere around 35 years. We unnecessarily keep on arguing HbA1c less than 7, less than 6.5, but if we see the ground data, 2/3 of the patients, they are not getting even single HbA1c in the last 1 year. Monitoring and follow-up is extremely poor in clinical practice, and I think all of us can recognize as clinicians that, the follow-up is extremely poor. Out of the patients who do HbA1c, 2/3 patients, they have HbA1c more than 7. 2/3 of the patients, they have associated hypertension and dyslipidemia. 2/3 of the patients, they adhere to diet and medications, means 1/3 of the patients, they are not even taking your prescribed medications. And 2/3 of the patients do not adhere to exercise and self-monitoring of blood glucose. So you may be advising SMBG to your 100 patients, but out of them, 2/3 patients, they do not even follow SMBG. I think what we can clearly make out as of now, there are significant gaps in diabetes care in our population, and as healthcare physicians, all of us need to work very hard to improve diabetes care in our population. So it's not only micro and macrovascular complications, there are significant psychosocial complications of diabetes. So this is one study we published as part of DNB thesis in 2017, occurrence of and predictors of depression and poor quality of life. And what we could find out, more than 50% of patients of type 2 diabetes that we see in our routine clinics, they have associated significant depression. So I think these are another challenges, to address diabetes in our day-to-day setting. When we talk about important pillars of diabetes management, yes, we know it's diet, it's physical activity or exercise, medications, and the often ignored things are monitoring and education. And these two pillars, they are very, very important, and unfortunately, they are very much neglected in practice: monitoring and diabetes education. This is one study we published as part of the SPEED collaboration with one of the society in Guwahati with Dr. Manas Barua and one of the society in Nepal with Dr. Dina Shrestha. And we did this 2018 clinical practice pattern in the management of diabetes in India and Nepal. And we did questionnaire-based survey of practicing physicians and diabetologists from New Delhi, Guwahati, and Kathmandu. So yes, there were a lot of important things that I cannot discuss entire things in this meeting. But if I go about SMBG, so what you see here, even for the physicians who were recommending SMBG, it was only 35% for New Delhi, 24% for Guwahati, and looks sort of better for Kathmandu, 64%. So SMBG probably, and these are the physicians and diabetologists who are practicing, primarily in private practice, generally affordable patients. So probably as healthcare physicians also, we are not able to that often prescribe SMBG to our patients. Now, when patients, they have fluctuations in the glucose levels, more hyperglycemic spikes, more hypoglycemic episodes, that leads to more glycemic variability. And there's a lot of data, and I think we all know, more higher glycemic variability is clearly linked to more diabetes complications, more macrovascular complications, and higher cardiovascular disease and higher cardiovascular mortality. So definitely there's a need for novel interventions or better implementation of existing approaches to optimize glycemic control in clinical practice so that the patients can have better glycemic control and the complications, they can be minimized. When we talk about conceptual framework of SMBG, that is self-monitoring of blood glucose, there has to be a good collaboration between persons with diabetes and the healthcare team. So there are definite lot of advantages of doing SMBG. Definitely we can have glycemic assessment when they are coming with the logs. We know how much is their fasting, how much is their post meals. Based on that, you can take your good clinical decisions. And not only that, during that process, patients learn a lot of things. Once they they know that they are monitoring, they better understand about the disease. They better adhere to behavioral changes because they know when they have eaten something that is not absolutely right. They check their glucose levels; it is going high. So they can in practice in their day-to-day life, they can correlate everything, and that actually helps them in better sort of adherence to lifestyle interventions and better understanding about their disease. So eventually good monitoring. So monitoring is obviously, one is day-to-day monitoring, that is with the SMBG, and then you have periodic monitoring, whether it is like HbA1c every 3 monthly or once a year annual test for diabetes. So better monitoring eventually translate into better metabolic effects, good glycemic control, good control of other parameters, better safety, less hypoglycemia, better management of hypoglycemia, then good quality of life, and in long term, definitely that is going to translate into less costing for diabetes as well. When we talk about structured SMBG, so you must have realized in practice the patients, they have got a glucometer, but they often check like once in 10 days, once in 15 days, and that may be absolutely random checking every afternoon, irrespective of meals. That may not be that informative to the clinicians. So structured SMBG is nothing. It is simply when you ask your patients to check at predefined times. And this structured SMBG, it can be different for every patient. So suppose if it is a type 1 diabetes patient, you may like to do in pairing, pre-breakfast, post-breakfast, pre-lunch, post-dinner. If it is a type 2 diabetes patients well controlled on metformin and gliptins, you may just ask patients to do fasting and post-breakfast maybe just once in a week or once in 15 days. That is absolutely okay. If it is gestational diabetes, you may want more sort of aggressive monitoring like fasting and maybe every post meals. So this monitoring can be individualized, but this has to be structured. This has to be at predefined times, and the patient and healthcare team, we have to sort of make a collaboration that what times you are going to check, and this has to be taught to the patients. SMBG helps almost every patients with diabetes, whether it is newly diagnosed patients, whether it is long follow-up diabetes patients, whether on oral hypoglycemic agents, whether on insulins. So definitely once you have better monitoring, you can always take better decisions. Eventually better, more monitoring will translate into better glycemic control and less complications. Unfortunately, as I was discussing, SMBG is definitely underused in India. As of now, most of the glucometer devices, they are cheap. Even the good company devices, even your strips, glucometer strips, they becomes very affordable. But because of many challenges, whether we are not able to prescribe to the patients they are not able to understand, definitely it's not that optimally used in practice as it must be used. In my opinion, every diabetes patient who is on oral hypoglycemics or insulins, especially sulfonylureas or insulins, they must have a glucometer at home, unless there are some definite cost concerns, because you can do structured SMBG. Also, you can check at any time whenever the patient is having any unusual symptoms, whether it is hyperglycemic symptoms or hypoglycemic symptoms. So there's a lot of data you can see even in one of the private clinics from Delhi. Even the patients who were very affordable, only 28% of the patients, they had glucose monitoring device. Sometimes it is, it's not that it is cost issue. There are other logical issues. Sometimes I have seen patients who have a glucometer at home and they are not doing absolute monitoring for 6 months. And sometimes they have sort of, funny reasons for that, ki sir check karenge na to phir tension ho jati hai. So then another important thing is the accuracy of device. That is very important, because whatever readings we want to, because glucometers, they cannot be 100% accurate. As per the current recommendations, up to 15%, plus minus 15%, whether it is plus 15% or minus 15%, it is absolutely acceptable. Some companies, they are coming with new devices which can give variability within the window of 10% as well. But whatever window is there, the readings has to be within that frame, so that better decisions can be, because if readings are inaccurate, then definitely the patients will be misguided, treating physicians will be misguided. So better accuracy will translate into better short-term outcomes and better long-term outcomes. Then definitely the technology is coming in every field. It's not that only in the field of medicine, and technology has come in a big way in the field of medicine. The better technologies, they have come. Now probably, in next 2 years, the era will definitely, suppose, before 2 or 3 years, everybody was giving sort of writing prescriptions. I am still doing that. But now I have seen more than 50% of, patients, they are coming with printed prescriptions. So that is how technology is coming everywhere. Similarly for glucometers also, because now they can be integrated with the apps, through the Bluetooth technology. As soon as the patients check with their glucometer, Bluetooth is on, immediately it will go into the apps, something like My Sugar app, and immediately the readings will be updated in the app. And sometimes when they're coming with diaries, many times they come to your clinics ki sir hum diary to ghar pe bhul aaye hain. Sometimes they may checked several times कि हमने check तो बहुत बार की, but हम उसको लिखना भूल गए थे. Similarly, sometimes when the readings are high, they don't want to write, कि बाकी लोग देखेंगे कहेंगे कि कल इसने रसगुल्ले खाए थे, something like that. So, but on the contrary, if it is digital mode, once, as soon as it is checked, it will be immediately goes into the system, and by cloud-based system, it will immediately go into the cloud, and it can be, later extracted by anyone. Then definitely that reading is always there into the system. So what is really important? You have to individualize. You have to personalize. Every patient in practice is different, but monitoring is very, very important. Every patient, you have to think ki whether they want to, whether they have to have, in my opinion, almost every patient with diabetes who is on diabetes medications must have a glucose monitoring device at home. Frequency of monitoring can be decided by the treating physician. So this is so-called comprehensive, individualized, patient-centered, multidisciplinary diabetes care. We are there as a multidisciplinary care team. So it's not only doctors or physicians. We have team, whether it is dietitians, diabetes educators, nurses, everybody has a very important role. Similarly, there can be tools in terms of medications, delivery devices, and then you have education. That is the most important part to educate any patients. So coming to integrated personalized diabetes management, that is a holistic therapeutic approach. So it is nothing, it is simply interventional approach consisting of a structured disease management process which utilizes digital tools. So it is basically, bringing the healthcare team and the patients together, and it is simply nothing, it is sort of technology that, patients, they are monitoring, immediately it is going into a cloud-based system, it is immediately goes into the app, and this readings can be tracked by even the healthcare team as well. So there are 6 predefined steps which are repeated several times during this diabetes care process, and it can be individualized depending on the patient circumstances. So important components of this IPDM are structured education. You have to educate your patients. Then, as I was discussing, structured and therapy adapted SMBG. This has to be individualized for each and every patient. As soon as it is it is done, it is structurally documented immediately into the app. Then this app can do systematic analysis also. Immediately the app can tell ki mean average glucose over these days is this much, mean fasting is this, mean postprandial is this, and you can even sometimes, you know, give estimated HbA1c based on these average glucose values as well. Then once the patient is coming to you, you have all these logs with you, you can personalize your treatment, you can change your treatment based on that. And then once you make a change, you would again like to see the effect of whether whatever changes in the medications that you have done, it is actually translated into better glycemic control, and this cycle is keep on repeating. So I think that is, in this process, definitely better monitoring, better decision taken by the, because sometimes what happens in practice, patients, they are coming to me after 1 year and they have got a HbA1c that is 10.6. And they have, sir, ghar mein ek baar check ki that was 126. I am stuck everywhere. I really don't know which medication should I increase, whether the patient was adherent to diet or not. So I think monitoring is very, very critical. And the moment they monitor, you know, sometimes the patients, they are coming to us after 3 years, HbA1c is 12 or 13 because absolutely no monitoring was done in between. If they would have checked at least once or twice, immediately the readings would have been 250, 300. Probably they would have come to the doctor's chamber for follow-up. So this integrated personalized diabetes management can really help in achieving better glycemic control, improving time in range. Then definitely healthcare physicians, they can take better decisions based on the kind of data, based on systematic analysis of this data, and better solutions they can be offered to the patients. So as I was discussing, you know, as if the glucometers, they are digitally connected to a app, as you know, you can see here, as soon as the readings they are being done, it can be by Bluetooth technology, it will go into my sugar app, and you can see better graphs, you know, better sort of, you know, analysis of readings. You know how much time is spent in range, how much time is spent outside range, in hypoglycemia, and all these readings, they can even be sort of, you know, sent to your healthcare team through emails or, you know, whatever, if they have access to, direct access to data as well. So it's not that, you know, it's just random thoughts. All these tools, they have been developed based on science. There have been a lot of sort of studies which have been done, and based on that, only based on several feedback, only these kind of tools, they have been developed. So this company has done several studies. You can see STEP, Acure, Speedium Connect, and based on that only, you know, and after feedback from many senior physicians and diabetologists only, they have eventually come to this app only. Not only that, there is a scientific evidence that, you know, these kind of apps, these kind of integrated diabetes care can actually translate into better control. In fact, this is one of the study published in Diabetes Research and Clinical Practice in 2018. You can see more than 900 patients, 51 sites, and 1 year study. And you can see when the patients, they used this IPDM approach, it translates into better glycemic control, A1C reduction by almost 0.5%, 8% decrease in hypoglycemic episodes, and you see other benefits, better patient satisfaction, better adherence, better physician satisfaction, and eventually less micro and macrovascular complications, and probably you add years to life as well. So absolutely no doubt, you recognize so much importance of this IPDM, that is integrated personalized diabetes management, where there are a lot of, you know, sort of benefits to the patients. Persons with diabetes, they understand their diabetes better, they are adherent better, they have a connections with the healthcare team better. The healthcare professionals, they are also happy, they have better access to data, they are better able to take decisions, and eventually the system, you know, the follow-up and everything, it becomes better. So it is exactly doing now what patients need next, and that's all. Thank you very much.
Khandelwal, it was a very good talk, and the basic thing which Dr. Khandelwal has talked is the monitoring and education, and then getting these two things into the system, and making better diagnosis, better treatment of diabetes. Thereby we can prolong the life and we can reduce the complication of diabetes to a great extent. Now if there are any questions from the audience, please. There are no questions.
Thank you, sir. Any comments, sir, you want to make? Any of the chairpersons also? Any of the, yes, Abhinit.
cannot do anything regarding that. So what is the solution for that?
So basically, app is separate thing, monitoring is another separate thing. And old patients does not mean they do not know. And I know previously I also used to have the same kind of thinking. But if you do sort of, suppose using a glucometer, it is very, very simple. If the family members, they can be educated, and if they can educate the same sort of, patients several times, let me tell you, the things are easy. And then sort of, if they are checking with their glucometer, let me tell you, most of the old people, they are also running around with the smartphones. They can very well do sort of, chats on social media, WhatsApp, Facebook, everything. And if they can do so much, let me tell you, managing all these things are very, very easy. I think it is just into the mind that they cannot do it. Let me tell you, once you educate them, things are much, much easier.
Thank you, sir. Thank you.